welcome. So I hope you're all here to talk about learner handovers this morning. I'm Caretta-Weyer. I am the Associate Residency Program Director and Competency-Based Education Implementation Lead, mouthful, at Stanford University. And I'll let the rest of the crew introduce themselves.
I'm Stephanie Seabach-Sire. I'm an instructor in the Department of Emergency Medicine at Stanford University, and this is my partner in crime here.
I'm Lainey Yaris. I'm a professor of emergency medicine and vice chair for faculty development at Oregon Health and Science University, and I'm so excited to just hang out with the Stanford crew up here.
We're really excited you all chose to spend this morning with us. I'm going to give you a little bit of the lay of the land of what we're going to talk about this morning. These are the objectives. Hopefully you read them. But this is our outline. So we're going to start with a case because I want to get everyone in the right frame of mind to think about this. We're going to talk about what a learner handover actually is. I'm going to give you some barriers to implementation, some actual data from some research that we've done. The call to action, so why this is becoming such a big national conversation, actually international conversation. And then a content and process framework that we've actually come up with through, again, similar research. And then what to do with that handover data, which I think a lot of us in this room have probably had that thought of, well, if I'm going to start getting this, what on earth am I going to do with it? And then we're going to do an application exercise that these two have put together, which I think you're going to have fun with. So you're going to listen to me for a little bit, and then we're going to do some actual interacting. So our case. So this is a transition from medical school to residency case, and this is going to sound pretty familiar to all of you. So AA is a high-performing senior medical student who's matched into a procedural residency. All medical students complete an 8-week residency preparation course, don't we all wish that was true, in the spring of their final year of medical school, and simulated pages with registered nurses are a core part of the curriculum. The course director is contacted because AA has not returned 2 pages, and when the nurses were able to get a hold of her, they found her to be short and rude in her interaction with them. What would normally happen in this situation? Yeah, he would have no idea, right? So this would probably be a discussion between this clerkship director and this student. This information would not be used in any sort of decision-making around graduation. There'd probably be no remediation, nothing. And this intern would start with you, and you would have this blank slate. You would have no idea. So that's the normal phenomenon. The premise behind a learner handover, which has many, many names in the literature at this point, the learner education handover, the education handover, forward feeding, which has some negative connotations, but really honestly is a learner handover. This does not like me today. So basically it's referring to the sharing of information about a learner across educational phases. It's really the passing forward of information from one phase to the next. It can be from clerkship to clerkship. It can be from rotation to rotation. It can be from UME to GME. It doesn't matter. It is a passing forward of information. And I want to talk a little bit about barriers to this, because I think a lot of us are thinking like, I would love to have this information. There are a whole host of barriers. So UME and GME ought to be a continuum, and I'm going to make this argument. If you have heard me talk before, there's always a bridge. And all of these transitions in medical education feel like these insurmountable, unjumpable chasms, right? There are different silos, different phases. UME is its own thing, GME is its own thing. There's this gap in between the two that we don't really communicate across and we just kind of jump over. But that bridge and this bridge are the same highway. They're in 2 different places, but this is the exact same highway in California. It's one continuous road. And I would argue that that's what medical education ought to feel like. For learners, for us as faculty, each phase should be continuous with each other. And so we don't want it to feel like this. This is, again, the same stretch of highway gets washed out every couple of years. This is what it actually feels like to trainees, right? And so the goal is for it to not to feel like that. So what did we want to talk about? So competency-based education, again, the premise is that it ought to be a continuum. The whole premise is that you should start on day 1, you should work your whole life and retire, and it should feel like one seamless continuum across which you learn, you grow, you practice. And it should be on this attainment of desired outcomes. It's an end game focused process. You're focusing on these desired outcomes. And that's what the learner handover should be focused on. So this transition is often felt as discontinuity, and this learner handover is meant to address that. So one amazing paper that came out that Helen Morgan and Posse wrote for the AMA talks about kind of these best practice recommendations for a learner handover. And this is really the kind of the big paper that was out there for a couple of years. I believe Sally was on this as well. So it's basically this idea of providing medical school performance data to guide continued learner performance improvement. It should align with learners' continuous quality improvement, so it should really fit with the things that they want to do and to learn and continue to grow. And it should share this learner-driven information, perhaps in co-production with a coach. Coaching has taken on kind of this big role in medical education. And this idea of learners kind of doing this informed self-assessment and working with a coach and feeding that information forward has really become kind of a best practice. It should be done in a standardized format. I know a lot of us have gotten kind of some, maybe a learner handover here, a learner handover there from a given school, and they don't look the same, they don't read the same, they're hard to interpret, right? And it should be encouraging for both medical schools and residency programs to provide adequate infrastructure to support learner improvement. That's really the end game. That's what we're all here to do, right? We're here to help our trainees grow and develop and become, adaptive experts who are able to support their own learning once they leave us and go out into the wild. So, we decided to ask program directors about the current state of the learner handover from UME to GME and their frustrations. And I think you can kind of see where this is going. We did a case study of emergency medicine program directors. We did semi-structured interviews. We did a thematic analysis. And we found two kind of big core themes. That the learner handover is basically invisible at this point. And that there are a load of barriers to this. So what do we mean when we say invisibility? Basically, it is this. It's what handover? A handover implies that there is a back and forth conversation, and that doesn't occur. I'm handed learners, but there is no handover. I think that resonates with a lot of you. But then there's this idea of, well, there's the MSPE, so I am getting information, but that's not a true handover. That's a used car salesman document trying to sell me a student. So that's the current sentiment. So where are people finding kind of these barriers? So it's a lot of us versus them, right? UME is so focused on getting students where they want to go. The deans really. It's not just the students. It's the reputation of the school and the future matchability of the students that come after them, which limits their willingness to be honest about areas for growth. I think the only way people will be honest is it has no effect on the match. So this came up a lot, the residency selection process. There's no national standard everyone is compared to. Like, we have the EPAs, and that's what the goal is. But competence is local, and it's within context. You change the context, you have to reassess it. So there was a lot of kind of assessment context. That came up a lot. And then this concept of distrust or mistrust. So I don't really trust the deans are going to give me an accurate representation of who the applicant is. And they think we're going to misuse the information or hold it against the learner instead of taking a holistic view that everyone has areas to improve on. And it goes on. You have to decide where you compare to peers, similar arriving interns over the past couple of years. And we take the approach that people don't know anything, and we have to start from scratch. And I think this is the frustration we all have, right? You get, for us, 15 entering interns every year, and we know they're all different, and they're all starting from a different place, but we can't treat them that way because we don't know where they're starting from. This is probably my favorite quote, which is why I made it in here. I have never used certain sites, but if you go on Facebook or dating sites or those sorts of things, I feel like those sites have more information about people than we get from a learner handoff. So, clearly people are frustrated, have a lot of thoughts. And, the things that we took away from this were, obviously the residency selection process poses a big barrier to implementing this, right? You want to have the best possible outcome for each student. You want them to match in a place that they want to match. But that's a big barrier to getting kind of this growth-oriented information, right? but you want them to be growth-oriented, and you want to continue to help them grow. That's the whole point. There's this issue of lack of trust, issues around assessment, again, that it's context-dependent. We don't necessarily trust the school's assessment of trainees. And then we end up with this blank slate phenomenon. We have to start everyone from the same place. That's our solution that has been for a long time. And that's what we're trying to get past. So we're here trying to do some individualized learning. We want to make these individualized learning plans for trainees when they enter, to treat them in a way that they continue to grow along the trajectory they have defined. And we want to co-produce solutions. You have to think about this as UME and GME working together, or we're probably not going to get anywhere. So limitations, obviously, this is a case study just in emergency medicine, but I think this resonates with a lot of you. So we're back on the road, right? So we're trying to get everyone to this idea of a continuum. And there's been a big call to action recently. So I know all of you have read, hopefully, the entire 160 some odd pages. No, at least the executive summary from the Coalition for Physician Accountability, the UGRC. So a lot of these actually have to do with this idea of a learner handover, either directly or peripherally. So there's this idea of a common framework. That came up in our study. We're now all speaking a common language. How do we get to a common framework where we can have a conversation about what learners can and cannot do? So starting there and moving to how do we work UME and GME, so partners across the continuum, to committing to use robust assessment tools and strategies. Again, this is basically thinking, how do we trust the assessments we're getting, and how do we use them on the back end to continue to help learners grow? And then moving into this idea of a dashboard or portfolio, and giving this idea of consistent and equitable information during the residency application process and in a learner handover. So we're trying to put together this content, this process, this way of being able to transmit information that is useful both for residency selection and a learner handover. Do they have to be exactly the same? Potentially no. I think we all recognize that that's a big barrier. But that is a big part of this call to action. And finally, feeding back to medical schools. Again, this idea of co-production, you're getting this learner handover, being able to say, hey, you gave me accurate information or you didn't, and doing this continuous improvement of UME programs and the learner handover itself. So this idea of co-production, again, I'm going to keep coming back to this because GME can't do this in a vacuum, UME can't do this in a vacuum. We actually have to work together to combat a lot of that mistrust. So I'm going to give you guys a model, and that's going to be the last part of me talking. So back to what we talked about. So this is the best practices. And we took this to our group and said, these are the things they're recommending. And with this in mind, how do we get to a content and process that will work for our GME stakeholders? So again, continuous quality improvement, standardized format, learner-driven information. How do we get there? So we have a model. So how do we put that together? It's still our case study. It's still our same group of program directors. But this time we did a content analysis of what people were talking about, the things that they wanted. And the outcomes of that, not surprisingly, are this. So these are the 8 things that our program directors wanted in their learner handover. They talked about the progress on the core EPAs. They said, those exist for the medical schools. Do we get information about them? No. Are we meant to presume that every single learner is actually meeting all of them? I don't think that that's accurate. There are plenty of studies now to say that that's not accurate. But I want to know how they're doing on their differential diagnoses, on their plans, on their ability to recognize urgent and emergent conditions, on informed consent, all of these things, and the things that they're still working on. And then our team, and many of the people in this room actually, have been putting together emergency medicine EPAs, and we put them into buckets. So ones that focus on the transition to residency specifically, and then junior resident to senior resident into practice. We were like, we have those transition to residency EPAs. Why not get information about that? How they're doing on recognizing sick versus not sick, initiating initial management, those kinds of things. So I can focus on how to help them there. And then there was some EM kind of specific content. I know that a lot of this will resonate with you guys because this is our job. Our entire job, diagnostic reasoning and critical thinking skills. If you're going to think through how to diagnose and intervene on a given patient, we want to know how they're doing on those things, because that's what you spend a lot of your time doing. What is it that they're struggling with? What is it they're doing really well with? What do they want to work on in this specific domain? And then task switching. I know we don't expect our interns to be, these amazing task switchers, able to manage multiple patients, but it'd be great to know where they are on that. And then team leadership and communication. How are they doing when they're working in teams and resuscitations in, normal patient situations? Are they going back and updating the nursing staff? Are they going back and updating the family? How is that going? And then all of us in GME, our favorite topic, follow through on professional responsibilities. How are they with their paperwork? Do they follow through with things? Are they going to make our coordinators cry? Nobody makes Bianca cry. And then a couple of things at the end that people said, you know what, our greatest call in residency leadership at this point is to help our learners become self-directed learners. So what is their capacity for self-directed learning at this point? How are they doing on that? Where can we partner with them to help them continue to grow in that domain? And then strategies to facilitate personal well-being in residency. This came up a lot because this tends to be something that our trainees don't think about when they start residency. And then they get 6 months and they're like, I'm really tired. It's winter. I've been off service for 4 out of the last 6 months. I haven't seen my co-interns, et cetera, et cetera. How am I going to address that? And I think having them think about that up front is really important. So this is the content. And I think this will resonate with a lot of you, I hope, about the things that you would want to know. Then how do you get that information? Because some of that's pretty nuanced, right? So our group focused on this idea that they wanted to have a conversation. And I know that that is a huge ask, but people kind of framed it as, I'm sitting there and it'd be great if I could get the whole group of residency leadership team together on one day and have, the 15 EM clerkship directors or handoff directors or whoever it would be at the medical school just to call in and talk to me for 10 minutes. I get the document beforehand saying, these are the things that they talked about with either a coach or the clerkship director or the handoff director or whoever that they wanted to work on. And then they call in and give the context, the nuance, the things that I'm able to ask questions. And then that file is transmitted. So you have the document, you have the conversation, and then you have a conversation around what are the domains to target coaching for? What are the things I really want to focus on? If it's 3 things, 2 things, 1 thing that I really want to focus on for this entering intern during that orientation period, the first 6 months, what is it? And then that team sits there and says, you know what, just like we do after competency committee or we do with our coaches, how do we develop this individualized learning plan? How do we get them to focus on, these specific things that we get in the handover? So I don't know that the conversation is necessarily essential because I know that's a huge ask, but I do know that getting the content with areas for strength, areas for growth, that's co-produced by a learner and someone who knows them, so that informed self-assessment piece, so that you can talk about coaching and individualized learning on the back end is really the key. So, next steps. So the UGRC talked a lot about portfolios. Medical schools often have these in some way, shape, or form. Are they productive? Maybe not in their current content. However, if students are able to kind of put things into this repository and say, here are the things I'm working on, that alone would allow them to be able to feed some of that information forward when they're talking about, I've matched, I want my program to know the things that I care about working on and continuing to grow on, and something that we can work on with our UME colleagues. Eric Warm put this out actually several years ago now, and I think this is actually a really great model for that conversation or that document. It's called the class model. Think about this like iPass for a learner handover. So it's this description of what the learner's attained. So this is kind of like, you give your one-liner when you're signing out. You say, this is what's going on with the patient. A summary of the learner's performance. So here are the things that we've done. An action list of items to be completed by the program. So here are the things you need to do after I sign this person out to you. A statement of situational awareness of this learner's skills and behaviors. So similar to what you say, like, I'm concerned about this patient for these reasons. I think that they could go south in this way, this way, or this way. And then a synthesis by the receiving program, similar to what someone would do when you're signing out. Here's my synthesis of what I heard. It's exactly like iPass. So again, perhaps you're going to say, they have attained competence in most of the core EPAs, except for being able to identify or intervene on urgent and emergent conditions, the procedural competency, and perhaps the informed consent EPA. Maybe they're not quite so good at task switching yet at this point, and they have some trouble with sick versus not sick. Those are things that you can, think about. And here's a summary of everything that they've attained so far and the things they want to work on. Here are the things that I would focus on if I were you. I would work on helping them recognize sick versus not sick, and I would get them a lot of procedural exposure early on. 2 goals for the program. Things to watch out for: this person has a tendency to overcommit and be really hard on themselves. Those are things you might want to watch for. And then this program synthesizes that back. Give you something as straightforward as that. So again, I want to kind of emphasize this has to be co-production between UME and GME. It has to be this conversation or this dialogue back and forth in electronic form where you can ask questions and synthesize this information. And again, the end point is this idea of individualized learning. So, about to hand this over to Lainey and stuff. The whole premise is that we don't want to treat them like they're a blank slate. We want them to come in and know that we want to partner with them to continue to help them grow and develop over time, and we don't want to pretend that their entire medical school experience didn't happen. Because they did learn a lot. Some of them a lot in certain domains and less in others, and I think focusing on the domains that they probably learned a little bit less in and leveraging the things that they're really, really good at can really help us drive an individualized learning plan for them and develop into what we call master adaptive learners. So there's a lot of people in this room who know a lot more about this than I do, but the whole premise is for them to develop adaptive expertise, to be able to take a look at gaps in their learning or data or things that haven't gone entirely right and be able to plan their learning, do some learning, and have this informed self-assessment process where they can integrate that into their being so that when they go out into the wild and their medical director says, hey, you're not so great at this thing, and we're no longer there to help them, they have this process in place where they can address learning gaps that they have. And a lot of that comes from this idea of data. So a learner handoff may not seem like data, it is. Just because it's not all numerical, or if you do get a spider plot, you're just like, I don't know what to do with this. That's data, I guess. But a lot of the narrative that we're getting is data we can use to help inform this idea of coaching. So again, it doesn't need to be that you have professionally trained coaches on your staff. It just has to be someone who is willing to partner with your trainees and give them that 30,000-foot view of, hey, I'm looking at this data too. Here's what you're seeing. Here's what I'm seeing. How do we co-produce a plan and some goals so that you can continue to work on these things in a way that's productive? And we reassess this on a regular basis. All right, with that lovely AMA infographic about how this all goes together, I am going to turn it over to Lainey and Steph.
I'm going to stay close to the microphone here. So whenever you're doing this sort of work and you're doing the coaching with the learners, it's always helpful to have some sort of framework or something. And we're just going to share with you here an individualized learning plan and sort of like ours and what is the content of ours and what is in there. So, this ideally should be informed by, the handover data and co-produced with the trainee. So like just a quick show of hands here. How many of you at your institutions would say that your trainees drive the assessment process? Put your hand up if like that is the culture. Okay, look around. Much like, I guess, when Holly and I started at Stanford, that was our culture as well, where, the faculty were the ones that were saying, okay, we need to do this. Okay, let's talk about this. Let's do this. And, we've worked really hard to get to a place where trainees are now, tracking us down and finding people to give them assessments and give them feedback and things like that. And so this example that we're sharing with you has been iterated multiple times. And obviously you have to find one that fits for you, but we're hoping that this will give you some ideas of things to sort of look for. So one of the sections that we have on our ILP is this opportunities for growth and development. And this is where, we have them identify these areas of confidence or areas of strength And they complete this all before they meet with their coaches and things like that. And then we also ask them, what are some of those areas that are less competent? I used to be a classroom teacher before coming into medicine, and so it's just funny sometimes how people think, oh, if I don't tell you the thing that I'm not really good at, maybe you won't notice. And so I think sometimes we get that with our learners as well. And so really forcing them to think about, we all have strengths, we all have areas that we can be improving in. Let's put them down and let's work on them together. Another section that we have is the personal and sort of career goals, because it's really important to have sort of that professional development section, but also like the personal, like what's going on. And sometimes things are, residency is a long time, whether you're in a 3-year program or a 4-year program. I guess prior to recently, I used to joke that that was my longest relationship, was like my education. And so having a place to account for that, and having them be able to come up with the outcomes and the things that matter in both this area and in the area of their personal goals is really important.
All right, so we are going to transition into playing out a case for you about how this might actually go down when you co-create one of these ILPs with your residents, for the purposes of both helping them grow and then eventually informing the learner handoff. For the purposes of this, we are going to assume hypothetically that we have an intern, Holly. And intern Holly has already had access to her evaluation and assessment data. And she also has her own sense of how she's doing. She's done a self-assessment. And prior to her meeting with her APD, Dr. Seebach-Sire, she has actually filled out this form. And so I'm going to give you information about what her assessment data shows and what she has self-assessed. And as I'm giving you this data, I would like you to put yourself in the shoes of her coach and imagine how you would actually negotiate this conversation that you have with her. Because the steps are, she's seen the data, she self-assesses, she fills out the form. Now she's about to sit down with Dr. Seebach-Sire and have a conversation, and they're going to co-create the final version of this ILP. But you all, as the experts in the room, are going to give Dr. Seebach-Sire some tips before she has the conversation with intern Holly. Okay? So be thinking about your tips. So I am intern Holly, and what I know is that I have, sorry, thank you for one right before.
Okay. Here you go.
Yes. So what I know is that I have, I've been entrusted on EPAs 1 through 9, but I still need direct supervision on emergent interventions, procedures, informed consent, and quality improvement. I feel pretty comfortable managing single patients at one time. I'm at the end of my intern year, but I'm still focusing on task switching and managing a department. I do well when I function as a member of a team, but I've gotten feedback from multiple attendings that I'm timid as a leader, and that sometimes my closed loop communication isn't really received by members of the team. I'm pretty good at following through on my administrative tasks. I haven't received any feedback that I'm lacking in that. And I really am excited about feedback. I like getting feedback, but I have difficulty identifying those gaps on my own. I also have a propensity to overcommit on projects, and sometimes I have a difficult time managing all of the projects that I have taken on. So going into this ILP conversation, I've already identified that I want to focus on informed consent, and I want a lot of procedures. I know that I need to work a little bit on my resuscitation skills, sick and not sick, and task switching. I'm working on my communication style and trying to incorporate that feedback that I've gotten that says that I'm a timid leader. And I've actually been working with a coach to help set up my learning goals based on that data. I'm still looking on identifying the right opportunity to say yes on, and while I know that I'm overcommitting, I haven't yet figured out a way to stop doing that.
All right, so this is where we need your involvement here. I'm just about to go into this meeting. What are some things that you're thinking about in your head that you're like, ooh, if I was in this situation, what would I want to probe? What would I want to ask about? And just yell them out. We're a close group. You feel very far away, but we're a close group. Yeah, just yell it out.
I'd love to know a little bit more about
Other thoughts? Oh, sorry, there's like a motorcycle right here. I need you to be really loud, or sorry.
All right, make you repeat that again. Where are we going? Shout it out.
So I'm just gonna
I was just-
summarize. Okay.
I would love to have an exploration with her in terms of what she's devoting her time to, and kind of where those time sinks are for her. Sometimes actually getting it all out onto one big chart or even piece of paper helps you figure out what are some of the things that you need to remove from your plate.
Great, thank you. Other comments? Other thoughts going through your mind? I swear we did not deliberately place her in here.
I didn't even get the keys ahead of time. I'm not a plan, I swear. There seems to be a pattern there that I'd like to explore a little bit more, because if Holly isn't good at handling task switching, that might be a greater underlying problem if it's manifesting in her project work outside of medicine, outside of clinical, and she's also one person at a time in the department. If that is a trait that she tends to really like to laser focus, there are some small red flags that are going off in my brain around whether or not this is the job for her, and getting in on that now and having that reflection and thinking about it. If she is going to be an amazing internist, I'd like to get that now as an intern and counsel her towards her excellence, rather than having her get to third year and then keep failing at being able to task switch. Because it is something that not everyone can do at the same level that we might need them to be able to do in the department. There's lots of room in between, but there's a soft signal that's got some red flags because it's in multiple places.
Yeah, I think that's an important one, figuring out, is it nobody showed you how to do it, or you can't do it, you don't want to do it? Others? So I feel like we've sort of covered the potential timidness or the team aspect, a little bit more about the task switching. Any other comments? I'm just drinking. Yeah, go ahead.
Just regarding the part about being viewed as timid as a leader, I think it's important to investigate, has she just not had the opportunity? Different programs are set up very differently, where sometimes interns don't really have an opportunity to be in that leadership role. So is that more of the issue? And they got nothing in medicine or medical school because they were in COVID and had a virtual, EM, whatever. So is it just that? And maybe it's an opportunity for all the interns to be running recess in a sim situation or whatever. So it might be a bigger issue, just not her.
It's a really important point. Is it just one of them, or is it all of them? And that kind of changes your approach to how you teach.
With regard to overcommitment, just like prioritization, right? So, if she has a ton of things on her plate, but she obviously has some things otherwise that she needs to be working on, do we need to have her sit down and really prioritize what's truly important, and maybe bring from 5 or 6 items down to 2 or 3 that really mean something to her, and she's gonna benefit more from those 2 or 3 if she really focuses on those.
That's great. We'll take one more comment before we jump into what this coaching session might look like, if anybody's got any last thoughts. Okay. Are you ready?
Yeah.
Let's do this.
Yeah. I just want to say intern Holly had a lot of big feelings when somebody mentioned internist. Thank you, Dr. Chan.
So, hi. I just want to make sure this is close enough so you all can hear me. So, hi, Holly. How's it going?
Good, good. Thanks for making the time to meet with me today.
Yeah, of course. You know what? This is actually the best part of my job. Getting out of the clinical space and just being able to, sit and chat. I had a chance to review your plan, and Wanted to sort of go through, maybe we can start with some of these areas that you said you wanted to focus on and go from there. How does that sound?
That sounds great.
Great. So I see you've got something here about, informed consent and procedural competence. I'm wondering a little bit about why you put that one on there.
Yeah, I mean, I think I kind of have a white cloud, and I just feel like I haven't gotten very many procedures this year. And I know going into my R2 year, I really need to be like confident with those. And so I'm hoping that I can just find a way to get more procedures and do the informed consent so that I can just hit the ground running as a second year.
Are there any procedures in particular? Are there anything that you want to work on a little bit more?
I mean, most of the critical ones like chest tubes, central lines, A-lines, intubations.
Well, I'm going to make a note here for myself. We can sort of like check your schedule and see, like where you've been, and, maybe if we can move around some of your rotations to have you, do, let's say, anesthesia first or something like that. It's also sometimes a bit of like negotiation, I know, especially in like RED, because, everybody wants to do procedures, right? So it's like, negotiating a little bit about, who's going to do that. And I don't know if you have, awareness, but we typically try to have, our second years do them before, like, our seniors and things like that. So I think that'll probably just like come. But if it doesn't, feel free to let me know, and we can, keep a close eye on that.
Okay, yeah, that would help. I'm just kind of worried I'm not going to be ready.
Yeah, well, and some of that sort of stuff is like within your control, and you never know what's going to come, through our doors when we're working. But if you let people know, hey, I haven't done chest tubes, and I really want to do that. Let your team know, like let your attending know when you start the shift. Let the nurse know, charge nurse, best friend, right? So, these are just some strategies that, you can do to perhaps facilitate, and, we'll work together on this.
Okay, sounds
Cool.
good.
All right, so let's talk about this next one, recognizing sick versus not sick. What's that one about? Tell me a little bit about that.
I mean, I think that's the same thing, that I just haven't seen that very many sick patients. I don't know. I just, for whatever reason, I don't feel like they come on during my shift. And so sometimes there have been times when I get feedback that maybe they were sicker than I realized. And I think that's just a matter of numbers.
Yeah. Can you tell me a little bit more about like sort of that feedback, like when they say a little bit sicker, like is it something, because I noticed you also mentioned, I'm thinking of like the next comment about, seeing 3 or 4 patients at a time, an intern year is really designed for you to like, learn what emergency medicine is about, and like be able to spend time with the patients before we like throw you in there and, you're managing a whole ED. And so I'm just wondering, like, where do you think that feedback is coming from?
Yeah, well, I think it usually is like, I'll try to like see all my patients really quick and get some things started. And then I might be in a room kind of finding out more information, and I get paged overhead, like Dr. Holly to recess 1, and then the attending is doing a bunch of things, and it turns out that they've gotten a lot worse while I've been gone. But I haven't yet figured out how to like be on top of that. So I've gotten some feedback about that afterwards, that I should know. I should be more there.
Yeah, I mean, and that's tricky because you can't always be there. One of the things that I'm wondering about is like, what are the relationships like with other people on your team? Like I know, for instance, myself, if I know I'm going to be called to the recess room, I make sure that I chat with whoever else is on shift with me. Usually, like the senior or the attending, and just sort of be like, hey, I'm gonna go do this thing. Here's what else is going on in the department. Like, are you able to cover that? Like, just keeping that communication open with the nurses, with the techs, with everybody that's working in that zone with you. How do you like approach that, or have you approached that?
Yeah, I feel like I have a pretty good relationship with the nurses, but I don't. It always feels like I'm bothering them when I ask them to do things, and I'm still trying to figure out how to be more directive and get what I need in terms of their assistance with taking care of patients without them being off-put.
Yeah, I mean, we're talking about relationships, and like those can be tricky, but like, I can assure you that everybody in, here at Stanford, like they want to be here, right? Like, so you never have to feel bad about like, asking a nurse. I think, part of this is going to be like figuring out what your leadership style is, and figuring out, like how you're going to do that, but not a question of whether you are going to do that or not. Like, So I don't know if that's anything you've given thought to around, you know, how you're going to emerge as like a leader, right? Like, you know, because the goal is to get to attending and to be able to run the ED. Like, have you given any thought to that?
I mean, I just think I need more time and more practice. I think I do get that feedback during code sometimes that I need to be like a louder leader or more confident leader, but I'm confident if I know something. And I think if I know that I'm not sure what's going on with the patient or I'm not sure which drug, then I don't feel like I can just confidently say that because that doesn't feel right to me. So a lot of times when I get feedback that I need to be like a louder leader or more confident, it doesn't, I know that I need to do some more things before I'm ready for that.
Oh, okay. Well, that's really interesting. I don't know, the whole like being loud kind of like chaps me a little bit because, you know, it's like not being a leader doesn't mean you have to come in and be like, you know, all right, I am in charge and I am in command here. You know, like there are different ways to be a leader. And I think, you know, especially as women, we have to like really figure that out for ourselves of like, what does that look like? You know, obviously if you're, you know, you're running a resuscitation and like people can't hear you, like, you know, that gets into like that communication, but you don't have to, there's no like one right way to like be a leader, right? And so like the example that you were saying, like if you just don't know something, like, man, our pharmacists are amazing. I've never actually worked at a place where like, you know, half the time Brian, he'll just like come out and sit with us, you know, and he'll be like, hey, how's it going? You know, like that is it, you know, we have so many resources and there are so many people on your team that like if that's part of it, like being able to like make sure you have the information so that you can, you know, show that you're a leader, you know, think about who those people are, you know, maybe you don't want to come straight to your attending and be like, I don't know this, and then the next patient, I don't know this, you know, so like who's there, who can help you, you know, and help build those relationships, and then, you know, we can, let's keep a close eye on this, you know, like being loud, because, you know, sometimes that's other people's perception, and, you know, for myself, I really want to figure out, okay, let's look at these comments of, you know, where is this coming from, right? And, you know, maybe I can even, you know, come in and shadow you one day and just give you sort of my take on it as well.
Yeah, that would be helpful. I honestly don't know when I see the comments because they're kind of all together. I don't know who said what.
Yeah,
so.
well, I mean, it's designed that way. But yeah, I mean, I think, you know, that's when you think of like what emergency medicine is really about, you know, and sort of where you want to go, like let's figure that one out and keep a close eye on that.
All right, sounds
Cool.
good. Thank you.
Yeah. I'm just trying to think if I have any other comments here or things that I was worried about. Like, I did want to just like come back to this like task switching a little bit, like just to sort of be like, you know, emergency medicine is really about task switching. Like, you know, how's your year been in terms of like the expectations of what you thought emergency medicine was going to be like? And
I mean, I guess it's been pretty much what I thought, although I didn't really get to see patients on my emergency medicine rotation because of COVID, so I haven't really been in this environment before, but...
You know what? I'm going to make a note to Kelly. She's one of our like sim faculty, and, you know, like let's get you in and see if we can do like some sim and have some cases that, you know, we'll be observing specifically for this, and then we can like chat about, you know, what that was like, because yeah, it's really hard to like do something if you haven't had the chance to practice it, right? And then, you know, I just don't want you to get so far along, you know, throughout residency before you realize like, you know, how to do this, because this is such an important skill and one that's like absolutely critical to being in a good emergency physician. So I want to make sure that that's something that doesn't, you know, run away from us. So
All right.
does that sound all right?
Yeah, sounds good. Thanks.
Cool. Is there anything else you want to touch base about? Or?
No, I think that's a lot for me to
Yeah. Okay.
process. Yeah.
All right. Well, sounds great. Thanks so much for coming in.
Thanks.
Thank you all for coming. I want to do a quick wrap up of just the things that we talked about. So we talked about the learner handover. We talked about all of the barriers to the learner handover. But this kind of big call to action where this is coming. This is something that we're going to be talking about a lot more over the coming years, and we're going to start seeing implemented. And so we focused a lot on what to do with the information when you get it. I'm going to signpost that emergency medicine will be starting to pilot this pretty significantly over the coming years as part of our AMA grant, and then collaborations with, I believe, OB and a couple of other specialties. So hopefully the content and process we talked about here will be helpful. It's going to be an iterative process where you're looking for all of your feedback on things that you like, that you don't like, that you would like to see changed, and how it's working on the back end, because I think that is probably the most important piece is, what are you doing with the information? Is it helpful? Is it helpful for you? Is it helpful for your trainees? And if it's not as terribly helpful as you had thought it was going to be, what can we change in order to make it so? Because really this is for the end user in the end. So again, thank you for coming. If you have any questions, we probably have time for a couple, and we'll be sticking around. So.